Hi everybody, and welcome to our module on the female reproductive hormones. The female reproductive hormones are called the estrogens. I've shown the structure of the three important estrogens on the screen here. At the top of the screen is the structure of estradiol, which is also called 17-beta estradiol. The bottom right side of the screen is the structure of estrone, and at the bottom left is the structure of estriol. You can see that they are all synthesized from cholesterol, and they all have 4 rings like cholesterol. The potency of the estrogens is such that estradiol is the most potent, estrone is in the middle, and estriol is the weakest of the estrogens. Estrogen synthesis occurs primarily in the ovaries. Specifically, it occurs in the ovarian follicles. The follicles are the structural units of the ovaries. They consist of an egg surrounded by cells. This is a picture of an ovarian follicle on the screen here. This is an oocyte or egg at the center. It's surrounded by 2 layers of cells. The inner layer of cells are called granulosa cells. The outer layer of cells are called the theca cells. And the theca cells and the granulosa cells are the important cell types for synthesis of estrogens. The theca cells, which are on the outside of the ovarian follicle, take up cholesterol and convert it into an androgen called androstenedione. This process is stimulated by luteinizing hormone, which acts via a cyclic AMP second messenger system on the theca cells. The theca cells then pass the androstenedione to the granulosa cells, which convert it into estradiol. This process is stimulated by a different hormone, FSH. It also acts via a cyclic AMP second messenger system. And in addition to estradiol, the granulosa cells also produce inhibin, which can feed back and suppress pituitary release of FSH. This slide shows the biochemistry involved in synthesis of the estrogen hormones. The process begins in the theca cells, which take up cholesterol and convert cholesterol into pregnenolone. The enzyme that catalyzes this step is called desmolase, and it can be activated by luteinizing hormone. Pregnenolone then goes through a series of steps and is converted into the androgen androstenedione. Androstenedione is then passed to the granulosa cells, which convert androstenedione into testosterone. There is then a step that involves a very important enzyme called aromatase. Aromatase converts testosterone into estradiol, and aromatase can be activated by FSH. What aromatase does is it removes this carbon here and converts this ring into a ring with 3 double bonds. When you do that to testosterone, you get a molecule of estradiol. Aromatase can work on androstenedione, however, as well, and when you remove this carbon and convert this ring to 3 double bonds in androstenedione, what you get is a molecule of estrone, which is a weaker estrogen than estradiol. Estrone can then be converted to estriol, and so in this manner, aromatase plays a role in converting not only the very potent estradiol, but also the weaker estrogens, estriol and estrone. Here's an overview of the female reproductive system. The hypothalamus produces GnRH, which stimulates the pituitary to release more LH and FSH. The LH can activate the desmolase enzyme in theca cells so that they convert more cholesterol into androstenedione. The FSH can activate the aromatase enzyme in granulosa cells so that more androstenedione is converted into estradiol. And then the estradiol and also inhibin, which is produced by granulosa cells, exerts negative feedback on the pituitary gland and the hypothalamus. Let's talk about some of the effects of the estrogen hormones. Estrogens stimulate growth of the follicles in the ovaries. The theca and granulosa cells in the follicles make estradiol, and this drives follicular growth and eventually ovulation. Estrogens also increase the amount of sex hormone binding globulin produced by the liver. I talk about this in more detail in the module on reproductive hormones, but this leads to an amplification of the estrogen effects. Estrogens also have favorable effects on the serum lipids. They will raise the good cholesterol HDL and lower the bad cholesterol LDL. Androgens like testosterone have the opposite effect. Estrogens are very important at puberty. They lead to enlargement of the breasts in women. They lead to pigmentation of the areolas. You can also see pigmentation of the areolas in pregnancy when estrogen levels are high. Estrogens lead to development of the female body habitus, such as narrow shoulders and broad hips, also the female fat distribution in the breast and buttocks. One side note here is that pubic and axillary hair actually come from androgens. Women still have some androgens present, and that's what leads to development of pubic and axillary hair. Men have many more androgens present than women, and that's why they develop facial hair. You don't usually see that in women unless they have a problem where they have excess androgens, and that's called hirsutism. Estrogens also exert effects on the pituitary. They decrease FSH secretion via negative feedback, also LH via negative feedback, and there's one exception here, which I talk about in the module on the menstrual cycle, but estrogens can trigger the LH surge via positive feedback in the middle of the menstrual cycle. Moving on, now let's talk about another female reproductive hormone, and that is progesterone. This is the structure of progesterone shown on the screen. You can see that like estrogens, it is a steroid hormone synthesized from cholesterol. The main source of progesterone is the corpus luteum in the ovaries. This is a temporary endocrine structure that forms after ovulation in the ovaries and secretes progesterone. You can also get progesterone from the placenta during pregnancies, and small amounts are secreted by the adrenal glands and the testes. Most progesterone in the body is bound to albumin. It has a short half-life and is metabolized by the liver, and its main targets are the uterus, cervix, and vagina. We'll talk about the specific effects of the progesterone hormone on cells and tissues in a minute, but one easy way to remember what progesterone does is to recognize that many of its effects oppose estrogens. In fact, progesterone has been shown to decrease the expression of estrogen receptors in many different cell types. Another way to remember the effects of progesterone is to recognize that many of the effects are favorable to pregnancy, and that's why progesterone levels get very high in pregnancy. Progesterone is responsible for the secretory phase of the uterine cycle. I talk about this in more detail in the module on the menstrual cycle, but progesterone causes the uterus to prepare for pregnancy, and this occurs in the second half of the menstrual cycle. Progesterone also thickens cervical mucus, which prevents sperm entry. Progesterone also prevents uterine contractions. It does this through a number of mechanisms. It decreases the excitability of the uterus. It raises the membrane potential of uterine smooth muscle. It also causes uterine smooth muscle relaxation. All of these effects block uterine contractions, something that is very important for a hormone whose levels are going to be high during pregnancy. Progesterone also raises the body temperature slightly. This can be seen in women who are pregnant. Some women try to predict their ovulation if they're trying to get pregnant by measuring their temperature every day. When their temperature goes up, they know that progesterone is being secreted by the corpus luteum in the ovary, and this means that they have ovulated. And then finally, progesterone can exert negative feedback on the pituitary gland and inhibit the release of LH and FSH. Let's talk briefly about how hormone levels change over the course of a woman's lifetime. So during the reproductive years before menopause, estrogen levels are generally high because estrogen is coming from the ovaries. The estrogen levels are even higher in obese women, and that's because in adipose tissue, androgens like androstenedione are converted by aromatase into estrogens like estrone. And because of the high estrogen levels before menopause during the reproductive years, certain pathology that is estrogen sensitive is more common. So for example, endometriosis and uterine fibroids are two examples of pathology driven by estrogen, and so they're common during the reproductive years before menopause. When menopause occurs, estrogen levels fall because the ovaries eventually stop producing estrogen. There is still some estrogen in the body, however. There's continued lower level estrogen that's produced by adipose tissue. So although estrogen levels fall, they don't go to zero. And because estrogen levels fall at menopause, conditions that are estrogen sensitive like endometriosis and uterine fibroids usually improve and even go away entirely. You should know, however, that after menopause, unopposed estrogen levels are higher, and it's very high yield to understand this fact. After menopause, there's continued estrogen from adipose tissue, and there's no progesterone coming from the ovaries to oppose estrogen effects. This means that the endometrium is continually exposed to unopposed estrogen without having the counteractive effects of progesterone. This is especially true in obese women who have higher levels of estrogens after menopause. So because of the higher levels of unopposed estrogen after menopause, there's an increased risk of endometrial carcinoma in women who are postmenopausal, especially obese women. After menopause, even though estrogen levels have declined overall, unopposed estrogen levels are higher, and that's what leads to a higher risk of endometrial carcinoma. And it's super high yield to understand this fact. For the remainder of this module, I'm going to talk about oral contraceptives, which are analogs of estrogens and progesterone. They are called estrogens and progestins. And the way they work is to mimic the effect of the female reproductive hormones and exert negative feedback on the pituitary gland so that there is no LH surge and thus no ovulation. There are a couple different forms of oral contraceptives. Some are progestins only. One of these is the oral mini pill. Another is Depo-Provera, which is an injectable form of progestins called medroxyprogesterone. And then finally, the more commonly used oral contraceptives are combinations of estrogens and progesterone. Shown on this slide is the chemical structure of progesterone and estradiol. At the bottom left side of the screen is norethisterone, which is a progestin commonly used in oral contraceptive pills. You can see that it has a structure very similar to progesterone. It also has this unusual triple bond between two carbon molecules. This gives it a very stable structure so that it can be taken orally. The bottom right side of the screen is the structure of ethinyl estradiol. This is an estrogen that is commonly used in oral contraceptive pills. It also has one of these triple bonds between carbon molecules. So you can take a birth control pill that has a progestin component only, but this is rarely done, and we'll talk about why in a minute. This suppresses ovulation by mimicking the effects of progesterone and exerting negative feedback on the release of FSH and LH from the pituitary gland. These pills will also thicken cervical mucus, just like progesterone does. This will obstruct the entry of sperm, and there are some data that this may protect against pelvic inflammatory disease by obstructing the entry of bacteria. And then finally, the progestin-only pills will also thin the endometrium, which makes implantation less likely. One of the main disadvantages of progestin-only birth control pills is that they have to be taken at the same time every day. Now, this is true for all birth control pills, but it's especially true for the progestin-only pills. If you are off by more than 3 hours, you can become pregnant and you have to use an alternative form of birth control. In addition, women taking progestin-only birth control pills often have irregular bleeding and spotting. This can occur with any birth control pills, but it occurs commonly with the progestin-only pills. The advantage of these pills is that there's no exposure to estrogen supplementation. We'll talk about this in a minute, but estrogen carries certain risks and side effects when it's part of a birth control pill. Another progestin-only type of birth control is called medroxyprogesterone or Depo-Provera. This is an injectable progestin-only contraceptive that can be administered in the office by a physician via an intramuscular or subcutaneous injection, and you only have to give it once every 3 months. I mention this because you will frequently see this administered on your clinic rotations, especially to women who are poorly compliant with their birth control. You can have them come in every 3 months and get an injection of Depo-Provera. It's often called a Depo shot, and then they won't get pregnant for the next 3 months until they come and see you again.
Now let's talk about combination oral contraceptive pills. This refers to giving a progestin together with an estrogen. So as we've been discussing, progestins alone will work for contraception, but usually they're given together with an estrogen as a combination pill. And the reason for this is that there are a couple of advantages to adding an estrogen to a progestin. One of the big ones is that estrogen stabilizes the endometrium, so there's less breakthrough bleeding. When you give progestins alone for contraception, the endometrium becomes thin and friable, and that leads to lots of spotting and breakthrough bleeding. When you give progestins together with an estrogen, this problem improves. In addition, when you add an estrogen to a progestin, there's better suppression of follicular growth. The idea here is that the progestin suppresses LH and the estrogen component suppresses FSH. And then another benefit is that estrogen amplifies the effects of progesterone. In the setting of estrogen exposure, there are more progesterone receptors on cells, so you get more beneficial effect of the progestin than if you gave it alone.
There are a number of side effects and adverse events that can occur in women taking oral contraceptive pills. The first one is breakthrough bleeding. This is the most common side effect. I told you before that this can occur with progestin-only pills. It can also occur with combination pills. It's more frequent if the amount of the estrogen component is low. Different pills have different amounts of estrogen and progestin components. If the estrogen component is low, women are more likely to experience breakthrough bleeding. Hypertension can also occur among women taking oral contraceptive pills. This is usually mild, but the blood pressure may go up a few points. Thrombosis is the feared complication among women taking oral contraceptive pills. This is believed to occur because estrogen can increase the amount of clotting factors present in the serum. Usually this presents as a venous thrombosis like a DVT or a pulmonary embolism in a woman taking oral contraceptive pills. Rarely, these pills can lead to arterial thrombosis such as stroke or myocardial infarction. And then finally, there is a concern about cancer among women taking oral contraceptive pills. The data on this are conflicting. There is some evidence that oral contraceptive pills may lower your risk of endometrial and ovarian cancer. They may, however, increase the risk of breast, cervical, or liver cancer. There are 2 absolute contraindications to oral contraceptive pills, and those both relate to the risk of thrombosis. So in smokers who are over 35 years of age, oral contraceptive pills are contraindicated. This is because the risk of cardiovascular events and thrombosis is too high. In addition, women who have a history of a DVT or a PE also cannot take oral contraceptive pills because the risk of a second thrombosis is too high. And that concludes our module on the female reproductive hormones.